it is better now to invite Cecilia from Spain. She kindly accepted our invitation to make a presentation to share her knowledge on perinatal brain imaging, ultrasound, and or MRI. Cecilia, welcome. Would you like to share your presentation with us?
Yes, yes. Can you hear me?
Very well.
Perfect. Let me try to share the screen. Can you see it now?
Super. Yes, excellent.
Great, sorry, thank you. Well, okay.
All right.
Perfect. So my name is Cecilia Villalain. I work in Madrid. Thank you very much for the invitation to be speaking here today. It's an honor. And thank you to my colleagues in Madrid who are great mentors, and to the 3 medical students who helped me compile the data that I'm going to present to you today. So we're going to talk about the added value of MRI to neurosonography. And as you all know, central nervous system anomalies are the 2nd most frequent diagnosed prenatally. They entail a lot. They have big consequences for the newborn, for parents, and for societies. An early prenatal diagnosis is key mainly for 2 reasons. 1, we have to give adequate counseling to parents who must plan ahead and decide if they want to continue or terminate the pregnancy. And it's also useful for us, who must tailor follow-up and decide if delivery has to be at a referral center or it can be at the center of origin. Traditionally, the screening of central nervous system anomalies has been done by neurosonography, which has many advantages as it is very much available, it's cheap, it obtains real-time imaging, and it has good sensibility and specificity for these anomalies. However, it also has some pitfalls. It has decreasing sensibility with advancing gestational age and the ossification of the fetal skull. It also has decreasing sensibility with increasing maternal BMI or scars such as cesarean section scars. It's also very dependent on fetal position. This is why the MRI has been having an increasing role in the last few years. The MRI targets really well white matter, and this is why we like it for CNS anomalies. However, it's not cheap and it's not always available. We would always like to do as many techniques as we want and obtain as much information as we can, but resources are limited and we have to know when to perform certain techniques. So for me, we have to answer 3 questions in order to say if we want to do an MRI or not. And is MRI going to confirm my neurosonographic diagnosis? Is it going to add any additional pathology to what I've seen? And is prognosis or counseling going to change? Because if it's not, why do it, right? So in order to answer these 3 questions, I'm going to use 2 things. First, I'm going to present to you an interim analysis of our data between 2014 and 2019 with fetuses with any CNS anomaly, excluding spina bifida, with both neurosonography and MRI, and also a systematic literature review for the same years, including articles with a sample size over 100 fetuses. Our interim analysis is 121 fetuses, and it's 14 articles that I'm going to present to you very, very briefly, don't worry. So just to give you an overall idea of what we see in our clinical practice, well, we have actually 175 fetuses. I'm going to explain to you that we don't perform MRI on mild, isolated, non-progressive ventriculomegalies, but the rest we always offer the performance of an MRI. Most of our cases are referred, over 60% of them are referred. Most of them had a normal aneuploidy first trimester screening, although interestingly, almost 15% had an increased nuclear translucency. Most of them had an abnormal anomaly scan, mostly for CNS pathology, but sometimes they were referred for other pathology. So every time you find a first anomaly, look for a second one. Gestational age at diagnosis, the median is 21 weeks, but they get to our center later on, 26 weeks. And then the median time from diagnosis to MRI, it's 9 days. What we usually see, as everyone, are ventriculomegalies, followed by midline anomalies, posterior fossa or space occupying lesions. We always offer karyotyping or cytogenetic analysis, but not all of the women accept it. Mostly around half of them accept them. And only over the last few years, we've done RACGH. So we have 65 cytogenetic studies, but only 18 array, with 62 normal results, 1 Turner syndrome, 1 trisomy 18, and 1 variant of unknown significance. So first question, is the diagnosis going to be confirmed? For these, we use the classification proposed by Van Dorn, classifying our results in either confirmed, partially confirmed, or rejected. Luckily, over 90% of our diagnoses were at least partially confirmed. This was especially the case for ventriculomegalies, destructive lesions, or space-occupying lesions, maybe not so much for posterior fossa or proliferation, migration, and differentiation anomalies. How does this relate to literature? You can see this horrible table, which is full of data, but I'll guide you through it. Just take into account that there are very many different studies. Some are only one center, some are multiple centers, some are performed by experts, some non-experts. You have retrospective meta-analysis. And this is what happens in literature. You have many different answers to the same question. Does MRI confirm neurosonography? And look at this. Here you have like 50% confirmation in midline anomalies. It can go up to 89% on any anomaly. So when we look at the results and say, okay, our confirmation is around 90%, we are in agreement with these two groups, which are, if you think about it, just experts, which is our center, where neurosonography is performed by experts. So you can say that if performed by an expert, neurosonography is going to be confirmed in more than 90% of cases. That is, neurosonography has very high specificity. Is the MRI going to add any additional pathology? That is, how is the sensibility of the neurosonography? Well, it's good, but not as good. We have up to 20% of additional pathology, especially for the midline, posterior fossa, and proliferation, migration, and differentiation. And this is also in agreement with literature, although once again, it's very varying from one studies to others. For example, for isolated mild and moderate ventriculomegalies, as published by the ANSWER group or the MASHO, you can see that only 5% increase of additional anomalies. For example, look at the Meridian study. When performed by non-experts, the MRI is going to add almost 50% of extra anomalies, but only 24% if performed by an expert, which is more or less what we found in our study. Last but not least, is prognosis or counseling going to change? Well, it is. In more than 1 in 10 cases, the MRI is going to change the counseling you give to parents, especially for midline, posterior fossa, proliferation, migration, differentiation, and space-occupying lesions. This is also in agreement with literature, once again, very much dependent on if it's performed by experts or non-experts, but take into account that if by experts is 10%, it can go as high as 43% by non-experts. Just to show you a clinical case where we have found great use of the MRI, let's look at this 14-year-old girl who was pregnant with no remarkable history except for obesity, and she was pregnant with her first-line cousin's baby. First trimester screening was low risk according to gestational age. Second trimester, no anomalies, just increased uterine resistances. That's why we scheduled an extra scan at 26 weeks, where we saw some small periventricular cysts. We thought there were conatal cysts. We didn't think of infection at that point. We told the patient this was probably benign and just scheduled an extra scan. And here you can see the scan at 33 weeks. Look here, we're gonna see some cysts in the frontal area. And the white substance is hyperechogenic, little porous. Look at the cysts here. So now, this was not so reassuring for us. We ordered a torch serology, we ordered an MRI, and this is the MRI. Look at all the cysts around this area. White substance is affected as well. And the MRI was consistent with a severe CNS anomaly with cotothalamic subependymery cysts with frontal lobe extent, diffuse white matter disease, and after counseling, the patient opted for a termination of the pregnancy at 36 weeks after going through an ethics panel. 1 year later, she comes back, she's pregnant again, same partner. Now we're very much worried because she didn't want a genetic study in the previous pregnancy. First trimester screening, normal. Second trimester, no anomalies. We scheduled early screening at 24 plus 6 weeks, and this is what we find. Now we're really targeting the same area because we think this can happen again. And here you can see very small cysts, very subtle, You may miss it if you're not looking for it, or that they are. So of course, in this case, we were not so reassured. We ordered the MRI, we performed an amniocentesis, a chordocentesis, we did cytogenetic study, microbiology, metabolic study, torch was normal, karyotype was normal, ACGH was normal. Exome, however, was subnormal. We found a mutation in the gene HFE and 3 variants of unknown significance. Metabolic study was unremarkable, and the MRI once again showed caudothalamic subependymeral cyst with frontal lobe extent, diffuse white matter disease. Here you can see big cyst here as well. So she opted once again for termination of pregnancy at 36 + 1 weeks. And we counseled to change one of the gametes for next pregnancy. It's 2020, she's pregnant again with the same partner, and we'll let you know what happens. So in conclusion, we can say that neurosonography MRI tandem improves diagnostic accuracy in detecting fetal brain abnormalities, playing a relevant role in reaching a more precise prognostic assessment and obstetric management. And according to our data, diagnosis will be at least partially confirmed in over 90% of cases, great specificity. Additional pathology will be found in almost 20% of cases, especially for posterior fossa, proliferation, migration, and midline anomalies. And change in counseling can happen in up to 13% of cases. Thank you very much.
Excellent, Cecilia. That was a great, and I'm sure you're going to have many discussion later on about, you know, genetics and some other things. Thank you very much, and we will discuss a little bit later.